Good morning, everyone. I'm Dr. Andrew R. Christie Schwartz from Dermapen World, and it is with great pleasure in association with the very dynamic team from Pomico Cyprus and Dermapen World Cyprus to be presenting today's webinar, a mini masterclass on acne. To begin the session, I'm going to hand over to Christodoulos from Pomico, who will introduce the session and also just run you through a couple of things first. Over to you, Christodoulos. Thank you so much.
Thank you very much, Dr. Andrew. Καλημέρα σε όλους σας. Χαιρόμαστε που σας έχουμε μαζί μας για δεύτερη συνεχόμενη μέρα. Σήμερα θα είναι πιο συγκεκριμένο το σεμινάριο. Θα είναι ένα masterclass πάνω στην ακμή. Το διάλεξαμε επειδή την τελευταία φορά ασχοληθήκαμε με anti-aging και θέλαμε σήμερα να κάνουμε κάτι διαφορετικό. Όπως γνωρίζετε, η ακμή είναι ένα θέμα που ταλανίζει πάρα πολλές πελάτησες που έχετε σε όλες τις ηλικίες και που τη στιγμή το Dermapen είναι πάρα πολύ αποδοτικό σε αυτές τις περιπτώσεις. Σκεφτήκαμε ότι θα ταιριάζει για τη δεύτερη μέρα του σεμινάριου μας σήμερα. Χαίρομαι που βλέπω αρκετά συλλημπαρουσία από ό,τι βλέπω εδώ, κόσμος που ήταν και χτες. Το μόνο άλλο που θα ήθελα να σας θυμίσω σήμερα είναι ότι για τις υφιστάμενες πελάτησες που παρακολουθούν το σεμινάριο υπάρχει 10% έκπτωση στα retail των τελικών των καταναλωτή, 10% έξτρα από το 50% που παίρνατε και επίσης 30% στα professional serum που χρησιμοποιούνται κατά τη ώρα των θεραπείων. Περισσότερες λεπτομέρειες θα πάρετε από τα sales rep της περιοχής σας. Σας ευχαριστούμε ξανά που είσαστε μαζί μας σήμερα. Σήμερα θα είναι λίγο πιο μικρό σε διάρκεια, έτσι ώστε να μπορείτε να αφοσιωθείτε πιο συγκεκριμένα, επειδή θα είναι πιο τεχνικό το σεμινάριο και είμαστε στη διάθεση σας για τυχόν απορίες. Over to you, Dr. Andrew. Thank you very much for today again. And we're looking forward to this masterclass.
Good morning, Cyprus. I'm Dr. Andrew R. Christie Schwartz from Dermapen World, and this is the Dermapen World Acne Master Topic. We've specifically chosen to present this topic for you today, as this is one of the more controversial skin indications. The reason why is that many practitioners globally believe that if you were to treat a condition such as acne with Dermapen, then the risk is going to be spreading the infection further and therefore making the condition worse. What I want to share with you is a very scientific journey and discovery about the acne condition. I want to break down a lot of misinformation that exists within the market, but to also open up new opportunity and successful treatment protocols with Dermapen World. This includes a synergy of solutions with Dermapen 4, with the MG Collection CLR, home care with DP Dermaceuticals, but also in-clinic use of the Uber Pro chemical peeling. To begin with, what I want to do is firstly explore some definitions and also just assess the acne condition overall. As you see on the screen on the very top left, we have pus. If you were to ask your average teenager what pus is, they would probably tell you that pus is a sign of bad hygiene, that pus is dirt, and pus is infection. I want to have a look at pus with a more positive approach. What you see in pus, and the reason why it has that white creamy color, is it's in fact white blood cells or phagocytic or macrophage cells that have successfully achieved a mission of phagocytosis. And this is the process where pathogens are removed and the skin undergoes a process to try and heal and repair itself. So although socially we view pus and we view pustules and cysts as being ugly and potentially being a sign of something that's not beautiful, pus is in fact a good sign. Pus is in fact the sign of a good immune system, but also a sign that the patient's body is trying to fight and trying to recover from the acne condition. So pus doesn't relate into how much dirt is on the patient's face. Pus doesn't relate into the hygiene practices necessarily of the patient. It's in fact a good visual endpoint that shows that the body is trying to fight the infection and trying to fight the inflammation caused by the acne condition. The next two terms I want to explore, which are open comedones and closed comedones. By the technical dermatological definition, acne is defined by three things. We have infection, we have inflammation, and then we have a level of congestion. What's interesting, and what I'm going to argue with open and closed comedones, otherwise known as blackheads or whiteheads, when you touch them, they don't hurt. When you also look at these images here where my cursor is showing, you'll notice that they're either black or they're a gray or white or creamy in color. They're not red. So this is a sign that there's no infection and there's no inflammation associated with this early stage or precursor to the true acne condition. With a blackhead, as we see where my cursor is showing, this is referred to as an open comedone. So as I move down to the hair follicle that we see on the screen, the reason why the blackhead goes black is because we have congestion superficially in the follicle, but with this congestion through this area, oxygen is still able to circulate around that plug of congestion. So a sign that the oxygen is circulating is the fact that when you extract a blackhead, you'll notice that the top of it has a darker gray or black color. That is oxidation of the congestion, which is normally a combination of waxy sebum, dead skin cells, and potentially some residue from topical skincare products, including makeup. From a blackhead, we then move into a whitehead or a closed comedone. The term whitehead in English can be a little bit confusing, namely because many practitioners will call a papule also a closed comedone. In regards to a closed comedone from a whitehead perspective, what we have is a greater buildup of clogging and congestion. And typically, this means that there is more lumps and bumps, to use some simple terminology. When you touch the whitehead, there's generally no pain. When you look at the color of the whitehead here, you'll also notice that it's not red. So this is a sign that it's lacking two things that would officially make it acne. There's no inflammation, but there's also no infection in this case. If you were to try and extrude or squeeze what's within that whitehead, you would normally find a waxy white discharge with this. Moving into our definitions for what I would argue are true acne, first we have a papule. A papule, as we see from this image, but now moving down to where my cursor is with the hair follicle, is defined where we actually have the sealing off of the follicle from the outside environment. So because the follicle is now sealed off, this actually prevents oxygen from being able to circulate or enter the follicle. As such, with a papule, we do see that there is inflammation. If you were to touch it, there is indeed some discomfort. So we know that the combination of inflammation and infection formally makes a papule an official part of the acne condition. The difference between a papule and a pustule, they are both sitting relatively in the same depth and area within the follicle. However, what lacks with a papule is pus. So we understand that with a papule, it's unresolved in regards to the process of phagocytosis. So with that inflammation, the body's trying to fight, but there's not been a successful phagocytosis. So by comparison with a pustule, there's physically pus. So if you were to put some pressure, there would be something to squeeze out of that. So with a papule and a pustule, we're looking at relatively the same level of depth, the same level of infection and inflammation, but a pustule has an element of resolution because we see the pus. When a papule becomes deeper, when a papule becomes more infected and more inflamed, then the papule develops into what we call a nodule in this case. So with a nodule, as we can see from the images, we have a more intense level of inflammation, a more intense level of infection that's placing pressure on the physical follicle. But in the case of a nodule, there's no resolution with phagocytosis, so there's no physical pus that you can see up the top. However, from a pustule perspective, its next level of severity is going to be a cyst. So a nodule and a cyst are generally sitting in the same area within the follicle, deeper down, the same level of inflammation. But just like the difference between a papule and a pustule is about resolution of phagocytosis, it's also the same with a nodule and a cyst. With a cyst, if you were to place a little bit of pressure, you would see the pus easily comes out. So we're looking at varying degrees here of inflammation and varying degrees here also of infection as well. The next term that I want to cover is known as seborrhea. And seborrhea is the technical medical term for someone who naturally has the genetic predisposition for an oily or exceptionally oily skin. I want to be very clear, and particularly as we explore the role of sebum, that the issue of acne is about the quality and the thickness of sebum, not necessarily the presence of sebum. So I want to argue that in many cases, it's just as easy for someone who genetically has a very oily skin to experience acne as much as someone who genetically has a drier skin. So it's about the quality and the thickness of the sebum, not necessarily the presence. So as such, I don't want to view sebum and I don't want to view those patients with an oilier skin as this being something bad. This is just part of their genetic makeup. And in a few slides' time, we will actually explore the composition, but also the role of sebum and understand that despite what the average teenager might tell you, sebum is in fact good. Moving on to our next slide, I want to develop on our classifications and focus on exactly what can be treated with Dermapen and how this can be treated safely. But I also want to explore types of acne and classifications that we are to avoid with Dermapen. The first term is very confusing for the English language. And the reason why is we see the word vulgar. And in the English language, the word vulgar is something bad. It's something negative. However, acne vulgaris translates from the Latin to generalized acne. So the term acne vulgaris is not an adjective that's describing the severity and the ugliness of acne condition. It's not talking about vulgarity. What it refers to is a generalized acne, which is normally a combination of open and closed comedones and papules and pustules. The next area to define is called acne cosmetica. The father of modern dermatology, he's unfortunately dead at the moment. His name is Albert Kligman, and he is also perhaps one of the world's foremost acne specialists. Kligman defined acne cosmetica, where there is the direct correlation from products which are applied topically onto the skin, which clog and congest. So with this, these ingredients which cause congestion of the follicle don't have a trigger of hormones. It's the ingredient itself that's causing the clogging and congestion. So because this is from application, typically of cosmetic products, he refers to this condition as acne cosmetica. Examples of this. We often hear that from supermodels to many patients and to many naturalists apply coconut oil to their skin, either as a cleanser or alternatively as a moisturizer. Coconut oil is a solid in room temperature. So we understand, particularly from the studies of Kligman, that coconut oil is one of the most clogging and congesting ingredients that you can apply onto your skin. In fact, Kligman gave it the highest rating of clogging and congestion. So an example like coconut oil applied onto the skin and a patient sees lumps and bumps is acne cosmetica. A very new term, which we never would have discussed 2 to 2.5 years ago, is called acne mechanica. Acne mechanica is the formal term for what we socially call maskne. Whilst this is called acne mechanica, it's not the true triggers and activators that you would see with normal acne. So there's many arguments, particularly from dermatologists, that state that all acne is hormonal from its source and trigger. But we understand with these two special cases, acne cosmetica is from topical application of products, and acne mechanica is actually a combination of inflammation that occurs from varying bacteria and from breathing within our mask, not changing our masks as frequently as what we should, friction from the mask on our face, which then creates small little papules and pustules on the skin. So this is not a formal form of acne, but rather a different subcategory that's kind of related, but not your official type of acne. Moving into our official forms of acne. In 1956, 3 very prominent dermatologists, as we can see where my cursor is, Pillsbury, Shelley, and Kligman, who I referred to for acne cosmetica, they defined acne into 4 stages. Stage 1 is comedonal acne. As I mentioned before, because this is lacking the inflammation and lacking the infection, many leading dermatologists would argue that this is not technically acne because it's lacking those 2 things. But otherwise, this is classed as stage 1. So it's a combination of both open and closed comedones. Acne stage 2 does have inflammation, does have infection, and we refer to this as papular-pustular. So acne stage 2 is a combination of open and closed comedones, papules, and pustules. Acne stage 3 we refer to as nodular cystic. And with acne stage 3, we have a combination of open and closed comedones, papules, pustules, nodules, and cysts. You can safely treat with Dermapen World protocols acne stage 1, comedonal, acne stage 2, papular-pustular, and acne stage 3, nodular cystic. Acne stage 4, as categorized by Shelley, Kligman, and Pillsbury, is called acne fulminans or acne conglobata, as we see here. Acne fulminans and acne conglobata are in fact a form of nodular cystic acne. However, there are some unique phenomena that occur with stage 4 acne. As an example, if we look at this comedonal acne here, you could use your finger or your eye to count the lesions. So I can count these with my cursor. 1, 2, 3, 4, 5. The individual lesions are very, very obvious to count. Let's look at papular-pustular and do some counting. 1, 2, my cursor over here, 3, 4, 5. As I move to nodular cystic acne, it's getting harder to count the individual lesions. It's as if they're sort of joined. So when we look at acne fulminans, this is where we have the trenching or the joining of multiple follicles together. So for example, we can count some of these lesions, 1, 2, but let's look at this larger lesion here. There could be 3, there could be 4 follicles involved. When we look at acne conglobata on this back, this is not scar tissue. This is active acne that is entrenched. So with this, there may be 4, 5, or 6 follicles that have joined. So as part of the acne phenomenon, what occurs is a plug that clogs and congests more superficially within the skin. So if we have a look at our images on the previous slide, you can see this plug has closed the top of the follicle here. With this process, if there is intense pressure and intense inflammation, then it places pressure and it tries to go upwards. But because there's a closed plug in the follicle, the pressure can't go up. So then the pressure tries to go sideways. However, in the case of acne fulminans, as it goes sideways, the follicles now begin to touch each other. So if the pressure can't go up, if the pressure can't go sideways, where's the pressure going to go? Downwards. So in this case, with acne fulminans and with acne conglobata, because the pressure goes down, it now starts connecting smaller trenches underneath the skin. And we do not treat stage 4 acne with Dermapen. You will need to pass the patient over to a medical professional or dermatologist, and they will require a course of appropriate medication. The final definition I want to have a look at is acne rosacea. The term acne rosacea officially stopped in the mid-1980s, yet we still hear this used by many practitioners. Acne has triggers including a change of sebum consistency, retention hyperkeratosis or clogging and congestion, and infection. The triggers of rosacea are an inflammation that then triggers an overvascularization, so an overproduction of blood vessels, angiogenesis, which then creates a further inflammatory response, which thins the epidermis and thins the dermis. So they're actually two very, very different conditions. So although you can have stage 2 papulopustular acne, and you can also have stage 2 papulopustular rosacea, the two conditions are very, very different. So we no longer use the term acne rosacea, and rosacea has nothing to do with the triggers and activators for traditional acne. So we understand what we can and what we can't treat with Dermapen 4. We're going to avoid acne stage 4, acne fulminans, and acne conglobata. The first area of a little bit more scientific approach that I want to have a look at is the role of sebum. If you were to ask any teenager, they would tell you that sebum is bad, and sebum is something that you must remove. So we see a whole host of advertising on television, a whole host of advertising on social media, and in magazines that tells us you need to remove sebum. Sebum is bad. You need to get rid of that sebum, completely strip it and cleanse it away. Otherwise, you will get acne. The role of sebum joins in as part of our skin's barrier function, otherwise known as the acid mantle. Human skin is waterproof. And what waterproofs this is a combination of sebum, a combination of other oils, including vitamin E, and including ceramides and free fatty acids. So despite what we commonly see on social media, human skin is not a sponge. So the role of barrier function in the acid mantle is to waterproof the skin to prevent any pathogens or to prevent any bad things that you put on the skin surface from penetrating in and causing attack on the skin. An example of this waterproofing is a duck. The role of duck's feathers, but if you've ever eaten duck, you'll notice that it's a very, very fatty meat. So if the duck didn't have this protective oils, if it went into the water or into a pond, and if the skin could absorb water, then the duck would sink. So this is evidence that the role of skin is a barrier. The role of barrier function in the acid mantle is to prevent absorption. When we look at the role of sebum, it reinforces the skin's biome as well as barrier function. So as part of barrier function, we look at sebum, vitamin E, which is also produced by the sebaceous gland, and also ceramides, which are produced by lamellar granules, otherwise known as keratinosomes in stratum granulosum in the epidermis. Sebum has an acidic pH. So the pH generally sits between about 4.5 to about 6.5. So this acidic environment now keeps and maintains a bacterial balance on the skin's surface to now promote and support the skin's biome or natural ecology. Sebum production is triggered by hormones. And from the triggering of hormones, this then creates and determines the role of what is called a sebocyte. A sebocyte is a sebum-producing cell. So we have our follicle, which is an example shown here. And then on the side of the follicle where my cursor is showing is the sebaceous gland. Inside the sebaceous gland, it contains sebocytes. And with these sebocytes, they produce and they contain sebum. The sebocytes, I want you to imagine, are a lot like a water bomb or water balloon. What happens is the sebocyte, which is full of sebum, then moves to the mouth where the sebaceous gland meets the follicle. The sebocyte then essentially explodes and releases the sebum, which then travels up the hair shaft, travels up the hair, and then is released onto the skin's surface. So with this process, we understand that the role of sebum serves to condition the skin, to waterproof the skin, to protect the skin, but to also maintain bacterial balance. So if you are to remove the sebum, then you're going to make the bacterial balance imbalanced. So we understand that by constantly stripping the skin, this is a high risk for creating bacterial imbalance and actually worsening acne. Sebum contains a very complex recipe and blend of lipids. There's 57% triglycerides. A triglyceride is a base oil. So olive oil is a triglyceride. There's 25% wax esters. So a wax is a lipid, but it's just not chemically an oil. An example of wax would be jojoba. We then have 15% squalane. With the squalane, it is again another form of lipid, but it's just not chemically an oil or a wax. We then have 2% cholesterol esters and 1% cholesterol. With this recipe, it's very exact. So we understand that the triglyceride count is exactly 57%, not 58, not 56. And we're going to explore how sebum regulates itself under normal circumstances in a few slides' time. I also want to show that sebum is ingenious with its design. We understand that the skin's barrier function contains our lipids, sebum, vitamin E, ceramides, free fatty acids, but we then have what we call NMF, or natural moisture factor. And this is your water activators, including free amino acids, glycerin, lactic acid, hyaluronic acid, then moving into urocanic acid, urea, pyroglutamic acid. So all of these are water activators. We understand that water and oil don't mix. So if you can imagine in a bottle, olive oil and balsamic dressing to make salad dressing, the olive oil and the balsamic, which is a water base, separate. But our skin's barrier function is in fact a water in oil emulsion. What emulsifies the water phase into the lipid phase is in fact the 2% cholesterol esters and the 1% cholesterol. So these two agents are what combine in our water activators, natural moisture factor, into our oil phase to now create barrier function. So this is a water in oil emulsion. There's a lot of rumors out on the market as to what can and can't make you oilier. I hear that if you cleanse your skin too much, then your skin goes, uh-oh, I haven't got enough oil, I better make some more. It doesn't work that way. Likewise, we often hear that if you eat fatty food, so if I have pizza, it's going to make me produce more sebum. No evidence. If I have chocolate, it's going to make me produce more sebum. Again, no evidence. If I hug someone who has acne, it's going to pass over to me like a disease. No. There's only two things that are going to get you to produce more sebum. Number one is hormones. So that's particularly puberty. But number two, as a very unique aspect of Parkinson's disease, for some reason, it encourages a higher production of sebum. So if you are aware of the American actor, Michael J. Fox, if you're also aware of the former boxer, Muhammad Ali, who's no longer alive, both of these patients had Parkinson's disease. If you look at interviews or photos of them, you'll notice that their skin is thicker and a lot waxier and shinier by comparison to other people's skin. And the reason why is just a part of the phenomenon of Parkinson's disease is that for some reason, it creates a stimulation and activation of sebocytes, which then sees a higher release of sebum, creating seborrhea. Understanding the role of supporting the skin's biome, but supporting the skin's barrier function. I mentioned previously that social media, television, advertising, and teenagers are all obsessed with cleansing and stripping away any sebum that they have. Makeup companies which produce oil-free cosmetics have us believe that sebum and oil is bad. We likewise see that we have sebum cleansers, we have pore refining, dirt removing, acne clearing cleansers, and all of these products and clay masks and celebrities putting toothpaste on their face, telling us that we need to remove sebum. There is nothing worse you can do than strip the skin if you are suffering from acne. The concept of stripping the skin or creating squeaky clean, I think, becomes ingrained in our minds from childhood. I remember as a child being bathed by my mother in the kitchen sink, and as my mother would wash my hair with soap, I could hear the squeakiness, and I was told that this is good. Likewise, I remember also as a child, as the house was being cleaned, the sound of window cleaner on the glass. And I was told that this is positive. This means clean glass. And I also remember when I had to do chores and I was taught how to wash my own dishes and glasses up, that I was looking for that squeaky clean sensation. This squeaky clean effect has then led into our culture. And we're told that when we shower, when we wash our hair, when we wash our face, then we need to achieve that squeaky clean sensation. There is nothing worse you can do on your skin. And we see people using stripping cleansers. We see people using clay masks. We see people using charcoal masks, using toothpaste on their face, alcohol, kitchen cleaner, methylated spirits, a whole host of things, stripping their skin, thinking that this is going to help their acne condition. Although we're often told in advertising and when we study that the pH of human skin is 5.5, it's not. There's a range. So skin pH ranges from about 4.5 to 6.5. The nature of the acid mantle, as you can tell from the term acid mantle, is an acidic solution. We tend to find that the acidity of the skin can sometimes relate into the Fitzpatrick skin type. A Fitzpatrick skin type 1 and 2, so a fairer skin, tends to be more acidic. So it tends to sit around about 4.5. A Fitzpatrick skin type 3 and 4 tends to sit around about 5.5. But interestingly enough, darker skins, a Fitzpatrick 5 and 6, tend to have a slightly more alkaline pH of their acid mantle, which can go up to 6.5. So the reason why it's not advisable to use aggressive chemical peels on a darker skin isn't to do with the skin color exactly. It's actually to do with the higher pH of a darker skin. So with this, it means that there is a significant difference when you apply a chemical peel, for example, at a pH of 2, there is a bigger jump for that skin at a pH of 6.5 to then move down to the pH of 2. I want to relate this into what is called pH logarithms. So this is going to take you right back to mathematics class at school. pH logarithms puts a very different approach and thought on cleansing of the skin. For example, particularly for acne patients, typically in our minds, we go, if they have oil, then we need to prescribe a very, very foaming cleanser. We need to provide a mousse cleanser or something that is going to strip and remove all away that oil so that they can achieve the squeaky clean effect with this. So when we have a look at pH, we commonly believe in the beauty market that if you change the skin's pH slightly, then all you need to do is apply a toner and it reacidifies the skin. This is impossible. So I want to share these logarithms. So let's begin and working with a skin pH of 5.5. So your standard Fitzpatrick 3 and 4. If you cleanse your skin with a product which has a pH of 6.5, a product of 6.5 has a slightly more alkaline pH. This is good because it will remove excess sebum, but it won't start stripping away the skin's barrier function. The difference between 5.5 and 6.5 is not one step. It's actually 10 steps. So when you remove barrier function, the skin needs to recover. 5.5 to 7.5. 7.5 would be a well-formulated, low foaming cleanser. So this then takes the skin away from its natural environment by 100 steps. A pH of 8.5 would be a standard foaming cleanser. So when you apply a pH of 8.5, that's very alkaline. So the patient would feel squeaky clean skin. So this would be your standard acne, oily skin foaming cleanser. It actually takes your skin 1,000 steps away from its natural environment. As we begin to move into a pH of 9.5, which would be your oily skin, acne-prone, deep cleansing, high foaming product, that takes your skin 10,000 steps away from its natural environment. A pH of 10.5 would begin to be bar soap. So whether there's a quarter moisturizing cream within it, no matter how much glycerin or no matter how many essential oils or natural fats there is, it is still soap. And soap is alkaline. So with this, When you wash your face with soap, it takes your skin 100,000 steps away. Until finally, we move up to a pH of 11.5. I'm still very surprised that these types of products are still available in the market, but two of the most common facial bar cleansing soaps, dermatologist approved, of course, as it says on the packaging, these have a pH up to 11.5. So this takes your skin 1 million steps away from where it should be. This is very problematic. When you strip barrier function, you strip your skin's waterproofing agent, which now opens your skin up to intense inflammation. When you also strip the acid mantle and turn it into an alkaline mantle, you completely disrupt the natural biome of bacteria, and the alkalinity forms the perfect environment for acne bacteria to live and thrive. When you strip your skin to achieve this squeaky clean effect, the beauty market would say, all you need to do is apply a toner and it re-acidifies the skin. No chance. That's absolutely impossible. What actually happens is the only way that your skin can re-acidify itself is to produce sebum. And the process to produce sebum, so messaging from our hormones, then sebocytes producing sebum, this can take up to 8 hours before the sebum recovers and then is able to coat the skin's surface. So as an example, I want you to think of a phenomenon where patients want to be good. They want to do everything that you tell them to. They want to follow every instruction, and they want to make sure that they can clear their acne as quick as possible. If they use an aggressive cleanser in the morning, if they then use the same aggressive cleanser before or after they go to the gym in the afternoon, and then if they use that same aggressive cleanser for that squeaky clean sensation before they go to bed, if you use the cleanser 2 to 3 times a day and it takes up to 8 hours for your skin's acid mantle to recover, then this means that the skin has 24 hours a day, every day, of an alkaline mantle. So what you cleanse your skin with is paramount. Stripping squeaky clean sensation is bad. If you feel that your skin is dry or tight after cleansing, you are on the wrong product. If you feel your skin is squeaky clean, your skin is stripped, your biome is compromised, your acid mantle is destroyed. So we need to understand that for an acneic skin or for seborrhea, that we need to remove excess. We don't need to go down to baseline and remove everything. The DP Dermaceuticals CLR foam cleanser is designed for acne and an oilier skin. It's not designed for dry skins. It has a pH of 7.2. So you see that this takes around about 70 to 80 steps away. So this means that it will remove the excess sebum, but it will not remove your base barrier function. So understanding that what you cleanse with is important as one of the very first steps for treating acne. If your skin is stripped, you are on the wrong product. If your skin feels dry and you're running for moisturizer, you are on the wrong product. If it creates a squeaky clean sensation, you are using the wrong product. When we look at the acne phenomenon, there are 3 triggers and 3 activators that you need to take into account. Unless you treat all 3 triggers and activators simultaneously, you will never achieve a long-lasting result. As an example, you may have had patients who have undergone a course of microdermabrasion. Microdermabrasion targets exfoliation. They may experience success for a few months, but then all the acne comes back. Patients may go to their doctor, their general practitioner, who may prescribe antibiotics. The antibiotics will treat and target infection, but they don't target exfoliation, they don't target sebum quality. So after a course of antibiotics, it's not uncommon for the patient to then experience the acne coming back. So we understand that you've got to target all three triggers and activators simultaneously. If you don't, you will not have long-lasting success. The first consideration is increased sebum production, but it's not just about the sebum, it's the consistency. So the change of sebum into a thicker quality is a trigger and activator for acne. The second condition is clogging and congestion. So the fancy medical term for clogging and congestion is called retention hyperkeratosis. The third consideration for the acne condition is bacterial proliferation. And as a part of that bacterial proliferation, we then see inflammation. So these are our three triggers and activators: a change of sebum consistency, clogging and congestion, which then leads to bacteria. And subsequently, as a result of all of these triggers and activators, we then see inflammation and the acne condition. The first area I want to have a look at is how sebum is produced, and then also how we determine if genetically you are an oily skin person or a dry skin person, and how sebum production can go wrong and affect the acne phenomenon. Let's go through sebum production. The difference between a young child versus a teenager or an adult is puberty. So when you look at the skin of a young child, it's poreless, it's flawless. There's no major oil flow. You don't see open, dilated pores. You don't see acne lesions on the skin. So the obvious difference between a child by comparison to a teenager or adult is puberty and the role of hormones. During puberty, we have a message from the pituitary gland. If you stick your finger up your nose and tickle the base of your brain, that's where you would find your pituitary gland. The pituitary gland sends a message to the adrenal glands. Adrenal in Latin means above the kidneys. So the adrenal glands sit above your kidneys. There are two, one on the left, one on the right. The right-hand side one is a little bit different in shape. And because of this, arguably, this is one reason as to why normally your right-hand side normally will have more signs of acne lesions than your left-hand side. And it also links in with more increase of androgen hormones, which is the reason why normally you find your right-hand side should be a little bit more receptive to pain and a little bit more sensitive by comparison to your left-hand side. And this is the same reason why men have worse pain tolerance than what females do. So during puberty, we see signaling from the pituitary gland to the adrenal glands. The adrenal glands released testosterone. With this terminology, I want to be very clear that these are medical or official terms. Don't be frightened of these terms. Testosterone, when we hear this word, we often think of some angry Hulk gym man who's taken steroids. When we hear the word androgen, we think this is bad. How can female patients have androgen or male hormones? Likewise, when we hear the word hormone, we think that a hormone is something bad. A hormone is a signal. It's a messenger that creates a structure or sends a process. So none of these words are bad. The word steroid is a type or a category of hormone. So these are just definitions. These are not negative. The testosterone gets formed as a result of signaling from the adrenal glands. So they send the message to testosterone, which is an androgen steroid hormone. So estrogen is a female hormone. Androgen is a male hormone. So we call this testosterone is an androgen hormone, or what we call a male hormone. Its category, so the type of hormone that it is, we categorize as a steroid hormone. So this is just a category. This is not negative. With the release of testosterone, during puberty, what it promotes is the enlargement of the sebaceous gland. So as part of your genetic predisposition, if you have a large surge of testosterone during puberty, then this is going to create a larger size sebaceous gland. A larger size sebaceous gland, of course, is going to be able to hold more sebocytes, and with more sebocytes producing more sebum, this just means genetically you're an oily skin person. However, if you have a smaller surge of testosterone during puberty, then we have a smaller size sebaceous gland. This smaller size sebaceous gland is not going to be able to hold on to as many sebocytes, which therefore means that there's less sebum being produced. So genetically, you're a drier skin person. What we also get with testosterone and 5-androstenediol-317, which is actually an estrogen steroid hormone, we see this messaging from the adrenal glands, this messaging for the sebaceous gland to form, whether that's small, medium, or large in size. But then we also see the production of sebocytes, and sebocytes are responsible for the production of sebum. In this case, everything is running perfectly. However, the sebum in this instance is like the consistency of water. This is a big problem. So if I lick the back of my hand and then I blow it, it's evaporated. So we understand that water evaporates very, very quickly. So at this point, if we just have the role of testosterone and 5-androstenediol-317, then the consistency of the sebum is not going to be thick enough to protect and to waterproof the skin. So what happens is a process of conversion to thicken the sebum quality up. So we move from the pituitary gland at the base of the brain to the adrenal glands, which are responsible for the testosterone and 5-androstenediol-317 production. And now we're going to see communication from the adrenal glands to the testes, so in the testicles for men, to the ovaries, or the ovaries for female. What happens with this communication of pituitary to adrenal, to testes, or to ovaries is a process of conversion. And what happens is we see an increase of a metabolizing or a regulating enzyme that's called 5-alpha reductase. And what this does is converts 10% of the testosterone into the 10 times more stronger and powerful dihydrotestosterone. This is also known as testosterone 5 or DHT. What this conversion does, and the conversion is normally at a rate of about 10%. So we go pituitary gland to adrenal glands, and then at a 10% conversion from either the testes or the ovaries, at a 10% conversion, the sebum consistency now goes from water into the consistency of olive oil. This is not a problem. This is ideal because the consistency of olive oil is going to protect and waterproof the skin's surface and enable protection of the acid mantle and the skin's biome. The problem with the acne condition and the issue with sebum production and consistency occurs at this step here. If the conversion rate is more than 10%, 11, 12, 13, 14, 15, 16, up to 17% conversion, it then turns the consistency of the sebum from olive oil, which is not a problem and what it should be, into the consistency of room temperature butter. So thick, greasy, and heavy. And this is the problem. So the problem is not the presence of sebum itself, it's the consistency of the sebum. When we have a look at the role of 5-alpha reductase here, if this becomes imbalanced, then this promotes an overconversion. So we start converting above 10%. When this occurs within the body, there's a whole cascade of imbalances. I think of a guy I used to go to the gym with years and years ago. And I'm not super tall. I'm about 5'9", so about 177 centimeters. Also, if I stand up, I'm not a particularly large size person. I'm quite small. So if I went to the gym every single day and worked really, really hard, it's not going to be possible for me under normal circumstances to turn into a 120 kilogram muscle man. This is not going to happen. But for my friend who, my size, my height, went to the gym, but also took anabolic steroid injections, he then turned into a 120 kilogram muscle man. What I noticed though is all of these changes that occurred because the anabolic steroid injections imbalance and overconvert the role of 5-alpha reductase. So what happens is increased oil production. So when we see an increased oil production come through, it then opens the size of the follicle. So then we begin to see an oilier skin, but as the size of the follicle increases, if that follicle gets clogged, then we see more acne. So in this case, where the follicle is larger on the neck, on the lower part of the face where the beard is, and on the chest, not only did he have an oilier skin, but he also had a lot of acne on the face, neck, back, and shoulders, and the chest. What I also noticed is if there's an imbalance of 5-alpha reductase, it promotes an increase of terminal hair growth. So basically all the hair from here south, beard, body hair, all gets darker and thicker. So when you increase the size of the follicle, then the hair, its density can also increase. But what also happens when you have an imbalance of 5-alpha reductase, whilst the hair on your body gets thicker and darker, the hair on your head, which we call capillary hair, becomes thinner until eventually the follicle then sheds and becomes dormant. And then we begin to see androgenetic or male pattern baldness and hair loss. So that actually relates into a sensitivity of the 5-alpha reductase. So I want to show here that when there is a standard process of balance with hormonal production, sebum is good. But once this conversion rate increases and gets out of control, moves from the classic 10% to 11, 12, 13, 14, 15, 16, 17%, this is where the problem is. So the sebum goes from olive oil consistency into the consistency of room temperature butter. Factually, we understand that through this process, all sebum production, which then relates into potential acne, is hormonal, because what's creating the messaging and the signaling for the sebum production is from the pituitary gland to the adrenals, and then to the testes, or then to the ovaries. If we see acne and thickened sebum production, then we need to understand what regulates this production. What regulates the conversion is this enzyme, 5-alpha reductase. So if the enzyme 5-alpha reductase is not doing its job, then we need to find out, well, what manages 5-alpha reductase in the body? What manages 5-alpha reductase is zinc levels within the body. And one thing particularly with younger males is that they don't hold on to zinc so effectively. So if the body is depleted in zinc, then the zinc can't regulate the 5-alpha reductase. And if the 5-alpha reductase can't regulate, then it's going to be unable to balance the conversion for sebum consistency. So some considerations. One of the first things that you would want to check, and one of the first things that you would want to go through with the patient, is the role of zinc. So not moisturizer, not mask, but looking at zinc, because this is one way to influence. It's actually possible to purchase zinc tests. Zinc tests are a high concentrated liquid form of zinc. What you do is take a small sip of the liquid and swirl it around in your mouth. And then based on your experience of taste, it can then inform you as to what your zinc levels are. If it tastes like nothing, zinc levels are depleted. If it tastes a little metallic-y, then zinc levels are okay. If it tastes absolutely revolting, like rotten eggs, then your zinc levels are absolutely perfect. So this is a way that you can actually determine zinc levels within the body. This is something that's easily accessed even from a health food store. It's just a zinc supplement. So this is not on prescription. This is not dangerous. You can't overdose. Nothing bad can happen. Some other consideration apart from zinc supplementation, zinc is also found naturally highest occurring in shellfish, particularly oysters. But also be aware that the role of drugs such as phenothiazazine, which is found in antihistamines and in antipsychotic, which are a form of antidepressive medications, can also create an imbalance of 5-alpha reductase, which might then lead to an imbalance of sebum consistency. From our first trigger, an activator of acne, I want to move on to our second, and this is called retention hyperkeratosis. This is just the fancy term for clogging and congestion. So we understand that the skin undergoes a process of exfoliation, desquamation, and keratinization. So this is where we see the natural renewal and refreshing of the skin. When we have a look at this process of renewal, under normal circumstances, it's actually governed and managed by 3 checkpoints. To explain the first one, a growth factor is an agent that directs, manages, guides a chemical message or signal. So when there is a chemical message or signal that says exfoliate, this signal is managed through epidermal growth factor and also keratinocyte growth factor. These growth factors then influence the keratinocytes. The keratinocyte is the most dominant cell found within the epidermis. It accounts for 95% composition. The keratinocyte you find begins in basal epidermis. So on this image here, this is at this area here. With basal epidermis here, the keratinocyte begins a process of keratinizing or cornification, or the hornifying of the keratinocyte. So it starts off like a grape, and then it slowly dries out, and becomes a dried out raisin, and then it sloughs off. So we understand that the role of epidermal growth factors and keratinocyte growth factors become the first checkpoint for this signaling here, where my cursor is showing, for the keratinocytes to begin their process of keratinization. The next step to assist with the exfoliation is called a lamellar granule. The other term for a lamellar granule is a keratinosome. So a keratinosome is not the same as a keratinocyte. A keratinosome is a lamellar granule. Lamellar granules sit in stratum granulosum. So that is the mid part of the epidermis, where my cursor is currently sitting here. The lamellar granule contains a blend of proteinases, phosphatases, glucoside hydrolases. So the reason why I'm accentuating ases, is anything that ends with ASE in the body is an enzyme. What it also contains is another protein that's called corneodesmosonin. What these enzymes do is then send further signaling for keratinization and for the slowing release, beginning the release of these keratinocytes. So we begin with our keratinocyte in basal epidermis. Epidermal growth factors and also keratinocyte growth factors begin the process of keratinization. The keratinization occurs, and then there is a second intervention point in mid-epidermis here, where the lamellar granule releases enzymes, which then say, begin to release, begin to dislodge within the skin. The third intervention point is right up the top here on stratum corneum, where my cursor is showing. The stratum corneum used to believe to be just dead skin. It's not. It's a very active part of the skin. In the stratum corneum, we have what is called stratum corneum chymotryptic enzymes. The abbreviation for this is SCCE. The formal name for the actual enzymes you will never use in your life, but out of interest, they're called kallikrein-related dipeptidase 5, 7, and 14. So kallikrein-related dipeptidase 5, 7, and 14. The easy term for these, but again, you will probably never use this term, is called a KLK 5, 7, and 14. But otherwise, for simple terms, I just want to call them SCCEs, or stratum corneum chymotryptic enzymes. These enzymes that sit up the top here then send the message to slough off. So with this, we understand the renewal, the desquamation of the skin is 3 processes. Firstly, governed in basal epidermis here with epidermal growth factors and with keratinocyte growth factors. They begin the process of sending the message to keratinize. Then in mid-epidermis granulosum here, we then have the role of lamellar granules, and these send enzymatic messages which begin to dislodge and begin to disconnect the keratinocytes until eventually the keratinocytes then receive the message from stratum corneum chymotryptic enzymes to then release and to slough off. One area for consideration, particularly for those of you who work with traditional facials and traditional treatments, what's the one thing that you need to activate enzymes? For those of you who have washed your clothes and you use an enzyme stain remover, what's the one thing you need to add to that stain removing powder to activate it? I had to call my mother to get this answer. It's water. So if you deplete, dehydrate the skin and remove water, clay mask, over cleansing, stripping, over exfoliating, too many chemical peels, alcohol, drying the skin out, if the skin is dehydrated and there's a lack of water, then the enzymes found in lamellar granules, in stratum granulosum here, can't activate. Then the enzymes, the stratum corneum chymotryptic enzymes found up the top here, can't activate. So because there's no water and the enzymes can't activate, then the keratinocytes, dirt, debris, and follicular rubbish become stuck. They can't exfoliate, they can't extrude. So typically when you ask a teenager what a clogged pore looks like, they would draw all the dirt down here near the base of the hair. But you can see here where my cursor is showing, the base of that hair follicle is in the hypodermis. So clogging doesn't occur from the bottom up. The clogging and congestion of the follicle actually occurs from the top down into the follicle here. So we understand that if there is a slowdown of natural keratinization because the skin is dehydrated, then the combination here of thickened sebum, dead skin cells, debris is going to create follicular clogging, and then we get our congestion. So this is our official term of retention hyperkeratosis. So some people naturally will have a drier skin. Some people naturally will have impaired exfoliation. So this can contribute to further dehydration. But we understand that exfoliation without over exfoliating or stripping the skin's barrier function, but also keeping the skin hydrated is paramount. So it is very important that acneic skin still keep themselves hydrated and protected. So superficial ways to exfoliate your skin at home include the DP Dermaceuticals microderm exfoliant. There's lactic acid, which also hydrates. There's also micronized bamboo particles. To also hydrate the skin with a combination of enzymes and to also exfoliate is the CLR lotion for daily use at home. So this contains 2% salicylic acid to assist with exfoliation, but then also promotes hydration and a reduction of inflammation with niacinamide, manuka honey, and hyaluronic acid. In clinic, you can also exfoliate the skin with your DP Dermaceuticals MG collection, CLR, with your CLR lotion, but also with your Uber Pro chemical peeling. So we understand that there are ways to promote a regulated exfoliation, but without over stripping the skin. I'm going to look at the last trigger and activator, and then we will take a 10-minute break. The last trigger and activator is bacterial proliferation. With this, what occurs is when there is so much clogging and congestion, as we see on this image here, this creates a plug, which then seals off the top of the follicle from the outside environment. This plug then creates bacterial proliferation. The first consideration, when it comes to acne, we commonly hear what's called Propionibacterium acnes or P. acnes bacteria. This term is no longer used in the dermatology market. We actually refer with a new terminology since 2016, acne bacteria as Cutibacterium acnes or C. acnes. So when I say Cutibacterium acnes, this is the same as Propionibacterium acnes. It's just a more up-to-date. Believe it or not, everyone has P. acnes bacteria. P. acnes bacteria is, in fact, very good. Going back a few slides, you'll remember that I said that the triglyceride composition of sebum is exactly 57% concentration. The reason why it's 57%, not 58, not 56, is actually P. acnes bacteria. Within the follicle here, everyone within the sebaceous gland has P. acnes bacteria. What the P. acnes bacteria does is digests any excess triglycerides. So if there's too much of these triglycerides, a triglyceride is a triple chain of glycerol. So tri means 3, glyceride refers to glycerol. So if there's any excess, what the P. acnes bacteria does is breaks the triglyceride down into its glycerol, as you can see here, and then into free fatty acids. With this process, the P. acnes bacteria then consumes the excess glycerol, and then it just discards the remaining free fatty acids. Under normal circumstances, this is great because this means that the sebum quality and the sebum consistency becomes regulated. So you end up with this very exact recipe. So P. acnes bacteria is in fact good. P. acnes bacteria is argued to be one of the oldest living known species on planet Earth. And P. acnes bacteria lives and thrives in an anaerobic or oxygen-free environment. So it naturally lives just in the sebaceous gland here. And P. acnes bacteria is good because its role is to break down any excess triglycerides, separates them into glycerol and free fatty acids, and then works towards a better consistency of sebum. The problem is, though, when you have retention hyperkeratosis here, this follicle, which should be able to harbor oxygen, becomes sealed off. So this clogging and congestion creates this plug up the top here. When this plug takes place, it means that no oxygen can get into the follicle. So in this case, what happens is the P. acnes bacteria, which lives in the sebaceous gland here, can now begin to move and recruits into the follicle itself here. And the reason why it moves is because the follicle is now oxygen free. So we understand that the only reason why the P. acnes bacteria gets out of control is due to the anaerobic environment that's now encouraged within the follicle itself. What happens within the follicle is the P. acnes bacteria then begins to redigest any extra triglycerides. So it essentially goes in for a second helping. So as it begins to redigest triglycerides of already produced sebum production, what will happen is it consumes the glycerol, but as it then discards the free fatty acids, it essentially turns the follicle into a garbage dump. So as it then begins discarding the fatty acids within the follicle, the dumping of all of this rubbish at a faster rate creates inflammation. So you now have within the follicle infection, the P. acnes bacteria, but you then also have inflammation because of the rubbish dumping from the P. acnes bacteria. So with this, what now happens is the problem of bacteria is that it's fine when it's in the sebaceous gland, but when it's in the follicle, it's bad. It overproliferates, it then creates inflammation. Another aspect for consideration is that Cutibacterium acnes produces a self-cleansing enzyme that is called a lipase enzyme here. The role of the lipase enzyme is that it digests any excess fats, any excess waxes, and any excess lipids on the inside of the sebaceous gland wall here. So the lipase enzyme is like a vacuum cleaner or like a cleaning product that helps keep the sebaceous gland clean and functioning effortlessly. The wall of the sebaceous gland is very, very, very strong and very fatty, but the wall of the follicle is a lot weaker. So when you get movement of P. acnes bacteria or Cutibacterium acnes from where it should be in the sebaceous gland to where it shouldn't be in the follicle, not only does it overproliferate and then creates inflammation, but as it over-releases lipase enzymes, these then begin attacking the follicular wall. And as they attack the follicle wall, this then leads into distortion and then leads into abnormal collagen deposition. And this is the reason why you see post-acne scars, such as rolling, wave-like undulations, boxcar, a box or indentation, and then ice pick, which can also show from very dilated pores. So we understand that the acne phenomenon here at this point is all about intervening these triggers and activators, understanding how a change of sebum consistency creates the environment for retention hyperkeratosis. So we see the change of sebum consistency, then creating clogging and congestion, which then removes oxygen, which then sees bacterial proliferation. So how can we treat acne with Dermapen World treatments, procedures, and combination therapies? As I said at the very start of the masterclass, that acne is very controversial because many practitioners believe that they're going to be spreading the acne bacteria all over the face and are subsequently going to make the issue worse. The first consideration with this, your Dermapen 4 device creates 1,920 puncture channels per second into the skin. When you are delivering nearly 2,000 puncture channels per second into the skin, those puncture channels will facilitate oxygen. Oxygen kills P. acnes bacteria or Cutibacterium acnes. So moving on to our bacterial proliferation slide, just to explain, if you take a fish out of water, it suffocates, it can't breathe. So Cutibacterium acnes, which lives and thrives in an anaerobic environment, so without oxygen, if you then add oxygen with 1,920 puncture channels per second, then that oxygen suffocates or asphyxiates the Cutibacterium acnes. With Cutibacterium acnes, as it begins to overproliferate, it then also begins recruiting another type of bacteria. And this is called Staphylococcus epidermidis. Staphylococcus epidermidis lives on the skin surface. So when you increase P. acnes bacteria or Cutibacterium acnes, it then recruits and increases Staphylococcus epidermidis. But when you perform dermapen with 1,920 puncture channels per second, that then adds oxygen, which forces the asphyxiation or forces the degeneration of the P. acnes bacteria. It suffocates. And because the P. acnes bacteria dies, it then forces the reduction of the associated Staphylococcus epidermidis. With sebum regulation, dermapen 4, via the release of regulatory growth factors, particularly epidermal growth factors, helps to rebalance to achieve harmony. With dermapen 4, the same growth factors, epidermal growth factor and keratinocyte growth factor, also activate desquamation. So if we can promote through growth factors a regulation of keratinization, if we can also promote increased hydration within the skin, then this means dermapen not only uses oxygen to then kill the bacteria, but it then rebalances keratinization to minimize retention hyperkeratosis through the skin's hydration, and particularly through your Mg collection, but also regulating natural desquamation through the release of epidermal growth factors, but also keratinocyte growth factor. For sebum regulation, the CLR foam cleanser contains 2% botanical salicylic acid. With this, I recommend as you foam it up, leave it on for a minute or two before removing it, just to let the salicylic acid activate a little bit further. To reduce inflammation, the CLR foam cleanser contains aloe vera and Centella asiatica. Centella asiatica is also known as tiger grass. It is highly anti-inflammatory. And the role of salicylic acid also assists, because it is oil soluble, to break down excess sebum. The pH of the CLR foam cleanser is 7.2. So that means that it is a little more alkaline than the skin's natural environment, but this means that it removes excess, not the entire acid mantle. So you will not feel squeaky skin after using it. The CLR foam cleanser is designed for someone with a combination to an oily skin. I would recommend the tri-phase cleanser for someone with a dry skin. The DP Dermaceuticals Microderm Exfoliant works to enable a mechanical exfoliation. So it does this as a home care product, utilizing micronized bamboo particles, which are perfectly round, but also lactic acid. The lactic acid also increases hydration. So we understand that we want to promote a cleansing and exfoliation of the skin, but without over-treating, without over-exfoliation. Particularly for patients who pick and squeeze their skin, the color of the lesion can go two ways. It can either become a red macule afterwards, or it can become a post-inflammatory hyperpigmented macule, which means it turns brown. Dermapen procedures through the release of melanocyte growth factor, epidermal growth factors, and keratinocyte growth factor can help to alleviate and can help to speed up the recovery and healing of the skin, minimizing the appearance of post-inflammatory hyperpigmentation. Cucumber extract, as found in the microderm exfoliant, is a very potent, what we call melanosome transfer inhibitor. So it slows down the relationship and the transfer of the melanin from the melanocyte to the keratinocyte. Your essential, up-to-date procedural mesoglide must be the MG collection. The MG collection product exclusive for the treatment of acne is MG CLR. The MG CLR is multifactorial in its approach. It contains pyruvic acid to help serve as an oil-soluble desquamating acid. In fact, the pyruvic acid also helps to regulate desquamation. I forgot to put it into the column here, as a gentle way. So the pyruvic acid is more gentle than salicylic acid and can be safely infused into the skin with your Dermapen 4 device. So the pyruvic acid is at 2%, and the pyruvic acid works to break through thickened sebum production, but then also works to remove and to accelerate desquamation. To kill bacteria, the MG collection, CLR, contains a very specialized patidin peptide complex that's called oligopeptide 10. The oligopeptide 10 is specific for the reduction of Cutibacterium acnes. The MG collection, CLR, also contains Manuka honey. This is a medical grade honey that's sourced from New Zealand exclusively. And not only is it antibacterial, it's also highly anti-inflammatory. It's in fact used in hospitals for burn wounds. As potent anti-inflammatories, the MG collection CLR contains tranexamic acid. And whilst tranexamic acid is commonly associated for the treatment of hyperpigmentation, it's very effective as an anti-inflammatory, but also is very effective to reduce red macular post-acne scars. Niacinamide reduces inflammation, copper peptides, Manuka honey, and a plant extract called Boswellia serrata. So you can see that the MG collection is effectively delivered into the follicle with Dermapen 4. Dermapen 4 oxygenates, stimulates growth factors for hydration, for oxygenation to kill bacteria, and in turn reduces inflammation. But then the MG collection, CLR, further promotes exfoliation, reduction of inflammation, and disinfection. The MG collection, CLR, also contains a blend of pigment reducers. This includes tranexamic acid, kojic acid dipalmitate, vitamin C, which is called sodium ascorbate phosphate, licorice and niacinamide. So again, this not only reduces the appearance of post-acne red macules, but particularly for patients who squeeze post-inflammatory hyperpigmentation. As part of daily home care, the patient is going to use the CLR lotion. The CLR lotion contains 2% salicylic acid and also azelaic acid. This both serves as an exfoliant, but also serves to break through thickened sebum. So we see that it promotes sebum regulation, but in conjunction with lactic and a small amount of glycolic acid, it promotes a natural exfoliation. So you can see that this promotes a daily micro exfoliation. The same antibacterial patidin peptide, the oligopeptide 10, that's contained in the MG collection CLR, is also contained in the home care CLR lotion. So to reduce bacteria, we have an oligopeptide 10, the Manuka honey, but also tea tree oil. There's a blend of herbs to reduce inflammation. And so the blend of these plant extracts are potent in polyphenols and bioflavonoids, so antioxidant, anti-inflammatory agents. And the same plant extracts also work to reduce any risk of post-inflammatory brown hyperpigmentation. The Uber Pro should be part of your in-clinic procedures. For those of you with me yesterday's session was more about an introduction and more about a basic and starting procedure. Today's masterclass is for expert Dermapen World practitioners. And as an expert Dermapen World practitioner, for treatment of acne, my suggestion is not to give patients what I call the menu approach. The menu approach is when you say to a patient, what do you feel like today for your acne treatment? Do you feel like some Dermapen? Do you feel like some MG collection? Do you feel like some Uber Pro? What do you feel like today? And you tell me what your choice is, and I will react accordingly. No menus. If you want a serious acne treatment, you will set the dish. So a serious acne treatment with Dermapen World includes Dermapen 4, MG Collection CLR, and Uber Pro as part of your protocols. So don't give the patient the choice. This is the set formal protocol for this procedure. The Uber Pro contains oil-soluble exfoliating acids, which includes mandelic acid. The mandelic acid not only promotes sebum regulation because it is oil-soluble, but also helps to promote desquamation. In addition to mandelic, we have lactic acid and pyruvic and oil-soluble resorcinol. So this breaks down thickened consistency of sebum. To also help with sebum production, we've got a very potent form of vitamin A, and this is called retinaldehyde. The retinaldehyde is 20 to 40 times stronger than cosmetic grade retinol. So for cosmetic grade retinol to equal the effects of retinaldehyde, it would need to be 20% concentration. It's not allowed 1% in the EU. So you can see how powerful the retinaldehyde is. The Uber Pro is an anabolic peel. So it promotes a mesotherapy process of rebuilding. It's not like a traditional chemical peel, which promotes a process of destruction. So with this, the addition of ferulic acid, but also copper peptides reduce inflammation. It too contains a blend of kojic acid dipalmitate, retinaldehyde, mandelic acid, lactic acid, and arbutan, which is a precursor for hydroquinone, to reduce brown post-inflammatory macular marks on the skin. The final product that you will use in clinic, but I also recommend as part of essential non-negotiable home care, is the CliniPrep. The CliniPrep utilizes a hypochlorous solution. The CliniPrep is a disinfecting agent. When you disinfect, you also naturally reduce inflammation. So when you prevent bacterial proliferation, you prevent the subsequent inflammation coming through. What the CliniPrep contains is hypochlorous and phosphoric acid. Hypochlorous and phosphoric acid are what your macrophages naturally produce throughout phagocytosis. So the way your white blood cells physically remove pathogens, disarm them, but also asphyxiate them, is through the release of hypochlorous and through phosphoric acid. So the advantage of the CliniPrep is that it disinfects. It's a broad spectrum antibacterial, antimicrobial, antifungal, antiviral, antispore without drying, without stripping, and without irritating the skin. So it replicates the skin's own natural process of disinfection. So we understand that acne can be safely treated with Dermapen 4, but as part of a synergistic protocol. As I mentioned before, do not give the patient a menu. This is not a restaurant. For a solution, we are looking at Dermapen 4, MG Collection CLR, and for all patients, all skin types, all ethnicities, you can safely use the Uber Pro anabolic chemical peel. Moving on, I want to talk about contraindications and considerations. Firstly, if your patient is on any oral or topical antibiotics, this is not a problem to treat. Note, however, that with certain antibiotics, such as doxycycline, it can make the skin more photosensitive. So the patient must be using the DP Dermaceuticals Cover Recover every single day. The Cover Recover does not contain any ingredient that will cause acne or clogging or congestion. So they must commit to sunscreen. Also, with oral antibiotics such as doxycycline, sometimes it can make the skin a little bit more sensitive, which means the patient may bleed a little bit easier. So just be aware of this and adjust your needle depth. For topical antibiotics, the patient can use, so an erythromycin gel, they can use these right up to the day of treatment. This is not a problem, but they will need to reduce or remove this for 4 days during the post-op recovery. If your patient is using a topical retinoid that is prescribed by a doctor, so retinoic acid or tretinoin, again, they can use this right up to the day of their Dermapen for synergistic solution treatment. However, they must stop for at least 4 days during the recovery. I would recommend even a week. For patients who are on an oral isotretinoin, the names for this medication is called roaccutane, accutane, orotane, isotane. There are some parameters that have been suggested by a world-leading acne dermatologist and specialist, Dr. Martin Kergi, who's based in Zurich at a clinic called Outzentrum. His suggestion is a more up-to-date approach, as is the dosing for oral isotretinoin. If the patient is taking over 30 milligrams a day, so you would average it out, sometimes the patient takes their tablets every 2 days. So if it works out at over 30 milligrams a day, do not proceed with any aesthetic procedure. No Dermapen, no chemical peels, nothing. Just let their dermatologist or doctor manage. However, if the patient is taking less than 30 milligrams a day on average, then you can still proceed with your Dermapen treatment, even with the Uber Pro. This is not a problem. If you are unsure, check with the patient's prescribing doctor. If the patient is on the oral contraceptive pill, or if they're on anti-androgen medication, particularly for treatment of polycystic ovarian syndrome, or for treatment of hirsutism, where there is an increased hair growth, this is not a problem to still treat with your Dermapen World protocols. But note that some tablets may make the patients more photosensitive. Some tablets may make the skin more reactive. This is just to be aware of as part of your consultation process. You can use the DP Dermaceuticals LED, or you can use LED technology as part of a combination therapy. There's a big trend globally moving away from blue light because of the association with the UV and with eye damage. There's also a lot of updating data which understands that a red light, which is contained as part of the DPD LED system, that red light does also contain benefits to oxygenate and kill Cutibacterium acnes. So you can use this as part of a combination therapy, either with your standard Dermapen World procedure or the patient to come and see you in between each treatment. A big question is, what age can I start? You can treat a teenager, that's not a problem, but of course you will need parental permission for this. So with this process, as soon as the acne starts, then you can start treating with your Dermapen World protocols. Note, however, that there is no data that suggests that if you start treating a child who's 10 years old, that this would prevent acne from coming through. So remember that the acne is a hormonal trigger and activator originally. So we manage the condition with our Dermapen World protocols. Results last for as long as you can manage all 3 triggers and activators. So the hormones, which then manage the sebum production and then the sebum consistency, retention, hyperkeratosis, clogging and congestion, And thirdly, bacterial proliferation. If you do not target all three triggers and activators simultaneously, your results are not going to last so long. This is the reason why, again, I encourage that your protocols include a three-dimensional approach of Dermapen 4, MG collection, CLR, and the Uber Pro. Just some tips and tricks for diet and supplementation. Firstly, we often hear that chocolate and pizza and fast food is responsible for giving you acne, or if you work in an environment where you're touching lots of fatty things. No, it's not that easy. However, this topic has been explored by an Australian practitioner, Dr. Douglas Gross, and what he's found is that patients who are obese and patients who have an extremely long-term high glycemic index diet and high carbohydrate diet, this can then link into insulin resistance, which then in turn can lead to an imbalance of hormones and to the acne condition. This is further supported by an Indian practitioner, Dr. Jenny Matthew, who then supports the role of insulin resistance, so the pancreas then sending bad signals for testosterone production, which in turn sees an overregulation of the testosterone into dihydrotestosterone. So this can relate into pre-diabetics or type 2 diabetics. The other consideration is if we understand that what balances the 5-alpha reductase, which then manages the conversion of sebum consistency, if this is balanced through zinc, then zinc should be one of the first ways to influence through diet, but also even through supplementation. I spoke before about zinc tests. These are easily accessible. Zinc tests are just a concentrated zinc in a liquid form, so nothing bad can happen. This is not a prescription drug. You can get these easily from a health food store or even from a pharmacy or even online. Your taste sensation will then determine whether the zinc levels are good, medium, or bad. If the patient tastes the zinc and it doesn't taste like anything, that's a sign of low zinc levels, arguably. So with this process, the recommended daily intake of zinc is 23 milligrams a day. But if you are zinc deficient and your body's processing the zinc that remains in the body very quickly, there is support from many dietitians and nutritionists that it is possible to dose zinc supplementation for 1 milligram per kilogram the patient is. So if the patient's 50 kilograms, they could take up to 50 milligrams a day without negative consequence. If you're going to move into this area, I would suggest having a chat with the patient's doctor just to make sure that there is an element of safety and education. Let's look at our protocols. First, you must remove all makeup, all residue with the Tri-Phase cleanser first, particularly for heavy makeup. If you do not remove waterproof eyeliner, lipstick, heavy foundation to cover the acne, then you will risk stamping that into the skin and tattooing it. You can then do a second cleanse with the CLR foam cleanser. All of these products are available in bulk clinic sizes. As part of a more holistic experience and approach, you may wish to then do a very light mechanical exfoliation with the DP Dermaceuticals Microderm Exfoliant. Disinfect the skin with the with the Cleaner Prep, spray it on, or you can use the 500 ml pump and apply it. It needs 15 seconds to activate. After that 15 seconds, for all acne procedures, you will use the MG Collection CLR as your meso glide. Using your Dermapen, because your acne condition is sitting within the epidermis and you are aiming for a balance of keratinization and for a reduction in retention hyperkeratosis and the oxygenation of the top part of the follicle, your visual endpoint is no blood, but you are looking for pink to red skin. If you see no color change, your needles are too superficial. If you're seeing consistent blood all over the face, your needles are too deep. Note, however, as your dermapen goes over the top of any active papules or pustules, you will get some blood out of that individual lesion. This is not a problem, so long as the whole face is not consistently bleeding. So of course, if there's an active papule, pustule, nodule, or cyst, you may get some localized bleeding as you glide over the top of that. But make sure that the full face is not consistently bleeding. So essentially no blood, pink to red skin. The pH of your MG collection ranges between 4.5 to 6. If you do draw only blood, the pH of the blood is 7.48. The pH of your Uber Pro is 2.05. So you need to remove all post-operative residue using your CliniPrep solution before applying the Uber Pro. Otherwise, blood, MG collection, serum will neutralize the Uber Pro. So you need to make sure that you thoroughly remove all treatment residue at this point. You then apply the Uber Pro. The Uber Pro is about duration. So you want to work quickly so it is on the skin whilst the puncture channels are still open. The Uber Pro travels down those puncture channels to then allow for its benefit to reduce retention hyperkeratosis, post-inflammatory hyperpigmentation, to thin out, thicken sebum consistency, and to also promote desquamation. So it only needs to be left on the skin for about 30 seconds to 3 minutes. There is no benefit to leaving it on longer. Do not put multiple coats. Immediately over the top after the time, although the peel is self-neutralizing, you will apply the Hyla Active 3D mask, but bright light version. The bright light version has the addition of kojic acid dipalmitate to reduce post-acne macular red and also brown post-inflammatory hyperpigmented lesions, but also to assist with healing, the addition of superoxide dismutase. For a fast treatment, you can leave this on for 7-10 minutes, but otherwise you can leave it on for 15, 20, even 30 minutes. Use the cloth of the mask to remove any post-op residue. If you have any remaining MG collection, CLR, just use a few drops pressed into the skin, or you can apply a pump of the CLR lotion. For all Dermapen World procedures, they must end, never to be substituted, any of these products, with the vitamin-rich repair, then followed by the Cover Recover. It is impossible for the Cover Recover, which contains a broad-spectrum SPF 30 and a re-epithelializing silicone base, it is impossible for the sunscreen, for the silicone agents, and for the minerals that give it color to clog or congest you. So many patients believe that sunscreen clogs and congests. This is not possible. There was extensive testing done by Kligman, the father of modern dermatology, and his former business partner, Dr. James Fulton, who unfortunately is also dead, exploring which products do clog and congest you. There are no ingredients in the DP Dermaceuticals acne protocols or range that will create clogging, congestion, or further acne. Now looking at our treatment protocols and parameters. Your mesoglide must be the MG Collection CLR. You're going to treat every 2 to every 4 weeks. I'm going to share with you some patient case studies, and one of the practitioners said to me, the game changer for the acne treatment for her patient was swapping from every 4 weeks and creating tighter treatment intervals down to every 2 weeks to ensure a consistent procedure. So you treat every 2 to every 3 weeks. Note generally on day 2 or 3 following their procedure, you will probably get a phone call saying, I think you've made my skin worse. I think my skin feels pussier. This is very possible for many patients. And the reason why this occurs is there's a dual as the Cutibacterium acnes reduces and then the Staphylococcus epidermidis is forced to reduce. During that process, sometimes the Staphylococcus epidermidis can create small little pustules on the skin. This is not a problem. By day 4, day 5, this will resolve. My suggestion is that the patient uses the CliniPrep at home, and this will disinfect and reduce the inflammation, but also the response. On average, the patient will require about 3 to 4 procedures. So understand that although most patients see success after one treatment, this is a program. Your visual endpoint in clinic is no blood, pink to red skin. If it's comedonal acne, you can probably look for pink skin. But if it's papulopustular or nodular cystic, look for red skin. You will see some localized blood on some of the individual lesions, not a problem, so long as it's not consistent. We do not treat acne stage 4. You will use, as part of your synergistic approach, the Uber Pro. Automatically put this into your treatment protocols. It can be safely used on all Fitzpatrick skin types and ethnicities for a predictable, reliable result. What you do in clinic must be supported with patient home care. As we've discussed, there's 3 triggers and activators: a change of sebum consistency, retention hyperkeratosis, clogging and congestion, but then also bacterial proliferation, which results in inflammation. If your patient does not support this with use of the DP dermaceuticals at home, you will not achieve a result. The DP dermaceuticals is like toothbrush, toothpaste, and dental floss, twice a day, every day. You are a lot like the Dermapen World dentist. You direct and guide the overall treatment plan. I understand, particularly for younger patients, that it can be hard to afford both treatment and product. The most affordable way to get your patient onto the correct products is the problematic starter kit. So with smaller sizes, this is more affordable. But otherwise, there are 3 non-negotiables that your patient must be using to ensure success. The most important is the Clear CLR lotion. Hydrates, microexfoliates, reduces inflammation, disinfects. Your second most important product is the CLR foam cleanser. I guarantee in most cases that for acne, your patient is using the wrong cleanser. So they're either looking for something that creates that squeaky clean sensation, or they're using something that makes their skin dry. So the CLR foam cleanser becomes very important. The third is the CliniPrep, which can be used particularly post-op for any signs of any papules or pustules, but can be sprayed anytime throughout the day for ongoing preparation. If the patient can then expand into new areas, I would recommend the Retinol Active, containing potent vitamin A for nighttime, for post-inflammatory hyperpigmentation, the bright light, and of course, acne patients should still be wearing sunscreen every single day. The Cover Recover comes in 11 shades, so this can also be used as a daily camouflage, particularly for stage 2 and stage 3 acne. Having a look at some patient case studies, I want to begin from mild and work our way up to chronic. So we see here a 3-in-1 synergistic approach that is safe on an Indian skin. So this is the combination of DP dermaceuticals, Dermapen, plus Uber Pro. Again, for Caucasian skin, we see safety with this 3-in-1 approach. This is performed in 6 procedures and then 4 procedures for this final patient here for papulopustular acne. So you see success from comedonal, then moving into papulopustular where there's infection and also where there is inflammation. These next cases here are papulopustular acne, but then moving into nodular cystic. So a synergistic approach, this is 3-in-1. So DP dermaceuticals plus Dermapen 4 plus Uber Pro. So we see success for this papulopustular acne in 6 treatments and then 5 treatments for treatment on the chest here. So remember that acne may not just be restricted to the face, it will show up on the neck, the chest, the shoulders, and the back. Moving into severe cases. This nodular cystic acne here is from a hormonal imbalance. The patient is a bodybuilder. In this case, we have 10 procedures, but we have the 3-in-1 approach. MG collection, Dermapen 4, plus Uber Pro. This is the patient where the practitioner said that the results were better and longer lasting when they went from 4-week intervals into treating every 2 weeks. So we see a success. There is no medication or other combination therapies. For this patient of Indian background, we see safety and efficacy with our 3-in-1 approach of Dermapen, DP Dermaceuticals, plus Uber Pro, which can be safely used on all skins, and this is just 3 procedures. Moving into body areas, these case studies, they're both male, of course, but these are 2 different patients. So the first patient is 2 procedures. The scars that you see are from open heart surgery. So to remove the acne, a 3-in-1 approach. So we have DP Dermaceuticals, plus Dermapen 4, plus Uber Pro. There's also been some spot treatment on some of the scars and lesions using the Uber MD, but for our traditional acne, it's going to be the Uber Pro. This is also the case for this second patient here, which saw the same practitioner, but this is a different patient, 2 different cases here. And this is 3 procedures for the treatment of nodular cystic acne on the back. So the evidence is very clear, but the evidence also is very clear for the 3-in-1 approach of Dermapen 4, the MG collection, and also treatment with the Uber Pro. This standard treatment that I'm sharing with you on video is the same that you would use for acne, but also the same that you would use for hyperpigmentation. So you will notice that there's not a lot of acne on this patient's skin and also not a lot of hyperpigmentation. This is just for technique. Always cleanse the skin first with Tri-Phase Cleanser. If you then need to do a second cleanse with the CLR foam cleanser, not a problem. You can then choose if you wish to create a more holistic approach to perform a mechanical exfoliation with the microderm exfoliant. If you add water, it becomes more mild. If you use it dry, it's more abrasive. So you can choose your level of exfoliation. Note that the Uber Pro is always applied following the Dermapen, so we don't use the chemical peels before. Disinfect the skin with the cleaner prep, always, and then wait 15 seconds. I suggest that patients keep this in their gym bag as part of home care, in their office drawer to take with them to spray as required throughout the day for disinfection. For your acne, the evidence is clear that you will use the MG collection CLR. This is applied onto the skin using a Luer lock syringe, which connects in. And your visual endpoint is going to be no blood, pink to red skin. So these protocols are the same for both acne, but also for hyperpigmentation. So select your appropriate depth, and we will just use gliding technique, which means vertical, horizontal, diagonal 1, followed by diagonal 2. You will never need to use an imprint technique for your acne procedures. I choose to begin on the forehead because it tends to be the more sensitive area, so we just get it out of the way quick. You will not need use of a topical local anesthetic for these procedures. You're sitting above the nerve receptors. We then move on to the other side of the forehead. The video is sped up, of course, at this point. For the chin and jawline, I suggest that the patient tightens their lip over their teeth, like so. That supports the skin. With the forehead, you want to be working in an upward direction from the inside out. But with the chin and jawline, you want to work in a downward direction from the inside out. The treatment will be comfortable because you are sitting above the nerve receptors, you will have a response that will experience the vibration, but otherwise there's no sharpness or major pain. Same process of vertical, horizontal, diagonal 1, diagonal 2. So we now move to the second part of the chin and jawline. This is sped up. So you can see that there's some mild inflammation with the skin, but there's no blood coming out. Of course, if you go over an active papule, pustule, nodule, or cyst, there may be some localized bleeding, but otherwise, for the face, no blood, pink to red skin. So now moving on to the cheeks, and make sure that you change your depth from region to area as you work through. Never use circular motions, and always make sure that you have plenty of your MG collection CLR to enable a smooth, comfortable, efficient glide. There's 5 cc's or 5 mils of solution in your MG collection here. So that is plenty to treat a full face, even down to the neck. And then if you need to move on to the chest, shoulders, or back. Always the same directions of vertical, horizontal, diagonal 1, diagonal 2, working from the inside out. So we're now on the second cheek. The video is sped up at this point. I choose these areas, and I choose this approach just to give the patient a very comfortable procedure, particularly if I'm treating for anti-aging or scars. So I begin with forehead, chin and jawline, cheeks, eyes, nose, then lips. Always make sure that you are changing your needle depth as you work along so that you achieve the correct visual end point. We're now going to work around the eye area. Of course, we're working on the nose area. Every nose shape is different. So whatever gets you your 4 directions will suffice. This is also particularly beneficial for blackheads on the nose, and activating desquamation will physically extrude and push them out of the skin. Always make sure then when we move on to around the eyes that you are changing your needle depth, looking for the appropriate visual endpoint. Because the acne is not going to be on the eyelids or the under eyes, you may choose to skip treating around the eye area. That's not a problem. If you're treating for hyperpigmentation, which is a similar protocol, you can then treat around them. Always check just for your local regulations that you are able to treat around the eye area, particularly on the eyelid. Following this, we're going to conclude with the upper lip. But of course, if the acne is then on the neck, if the acne is on the chest, shoulders, or back, then move on to these areas, following these protocols, making sure that you achieve the correct visual end point. Do not overtreat. But as you can see, the treatment itself is very fast. So at full speed, it typically should take about 4 minutes, 5 minutes to treat a full face with DermaPen and the MG collection. And then the Uber Pro is left on for about 30 seconds to 3 minutes. And then you have your post-op with the Hyla Active mask. So we're concluding with this treatment here. On this note, I often get asked, will DermaPen be successful for ingrown hairs? The answer is no. For an ingrown hair, what we have is the attachment of the hair and the follicular bulb physically within the follicle, and then the hair gets stuck within the follicle. Unless you physically release that attachment of the follicular bulb, which DermaPen will not do, that will need to be done with laser or done with IPL, you will not see success. So this is for treatment, our protocols today for acne, stage 1 and 2 and 3. Following your DermaPen with your MG collection, remove any post-op residue so that you do not neutralize the peel. This is the Uber Pro distributed into a sterile kit and then applied onto the skin. Apply, watch, react if necessary, and then continue. The patient will feel just a tiny bit of warmth. It's not a heat, it's not uncomfortable. The patient will probably say to you that it smells strange. So there's a very unique, strong mandelic acid aroma. You can safely use the Uber Pro on all Fitzpatrick skin types and ethnicities. So this becomes part of your three-dimensional approach for the acne condition. Our post-op is always the same for all dermapen procedures. You will apply your Hyla Active 3D mask. In this case, I suggest the bright light version with the kojic acid dipalmitate, and with the superoxide dismutase, it accelerates healing, but also reduction of hyperpigmentation. The puncture channels are in the process of closing. So if you require a faster procedure, you can leave the mask on for 7 to 10 minutes. Otherwise, for a more relaxing experience, you can leave it on for 15 minutes, up to 30 minutes. So you can perform other treatments if that's something holistic during this time. Pressure point, lymphatic drainage. Note that this mask is not compatible for LED devices. The cloth, which is a spun lace non-woven rayon, will not allow the light to penetrate. So if you are wanting to use LED, you will need to use the DP Dermaceuticals LumiFuse masks, which are a clear gel mask which sits on the skin. They will allow the light to penetrate. Following the removal of the mask, removing the excess residue, you can re-disinfect if required. If you then have any remaining MG collection, you can press in a few drops. Don't massage too vigorously, or otherwise you can use some CLR lotion. So here's the remaining MG collection being gently pressed into the skin. And then we conclude with our standard post-op of vitamin-rich repair and cover recover. The cover recover, the patient can go to bed in, so they won't need to wash their face for the next morning. Always, as with all dermapen procedures, the patient must be using either CLR foam cleanser or triphase cleanser, vitamin-rich repair as seen here, and the cover recover for the 4 days post-op recovery. So this is the vitamin-rich repair. It's available in a bulk clinic size. It's 15 mils in the starter kit, and it's available in a 30 and in a 50 mil for retail. Following the vitamin-rich repair, we then apply the cover recover. The cover recover shear, as you can see where my cursor is, comes in a large clinic size, and the shear is color adapting, so it should suit most skins. Otherwise, if you need coverage, you can then use one of the choices of the 11 options which are available. Just for an easy application of the cover recover, just make sure that the skin hasn't got any heavy residue of vitamin-rich repair, and it will blend significantly easier. And then we will conclude with an application of the cover recover. This is our treatment protocols for acne, but we now also understand how we can achieve our success through our synergistic approach of dermapen 4, our MG collection CLR, and then with Uber Pro in clinic, but also as part of home care, the use of the DP Dermaceuticals to support and treat. That concludes our webinar for today. I've checked and the questions have been answered. I'd like to say a huge thank you. I realize that this has been a very technical topic to cover, particularly online. I certainly miss my whiteboard, being able to draw everything up for you. But a huge thank you from me. I'm going to now pass you over to Christodoulos from Pamiko. Thank you so much, Christodoulos, and a huge thank you to the amazing team at Pamiko for facilitating this event.
No, thank you, Dr. Andrew, for this superb masterclass. It was very informative for me. So, as you know, I have a business background, so I guess it was much more informative and interesting for the people who will use this in their salons in the coming months. We want to thank you again. We look forward to having you in Cyprus soon.
I can't wait.
And thank you everyone else for attending. Ευχαριστούμε πάρα πολύ που ήσασταν μαζί μας αυτές τις 2 μέρες και οτιδήποτε άλλο χρειάζεστε θα είμαστε δίπλα σας. Οτιδήποτε απορίες έχετε για ό,τι αφορά τις προσφορές που έχουμε για το σεμινάριο, μπορείτε να επικοινωνήσετε ή με το γραφείο μας ή με τις πολιτείες που σας βλέπουν. Ευχαριστούμε πολύ. Καλή συνέχεια. Yes.